Welcome back to the AETCM medical channel. I am Divya Rajan, a 4th year medical student, and today we will be performing a cardiovascular system examination.
Yes, proceed.
So now today we will be doing the examination on a mannequin to avoid disturbance to our patients. But please keep in mind that things like auscultation and percussion, it might not be that accurate as on a normal patient.
In a mannequin, it is not possible to percuss, but we are just demonstrating for the students.
Okay. So first we have to check the vitals, the BMI of the patient, and then we'll start with the general examination.
Okay.
So first we'll start with pallor.
Okay.
So pallor, why it is important is because pallor will indicate anemia.
Okay.
So anemia can present as syncope and palpitations.
Okay. Moreover, any anemia condition can trigger or aggravate cardiac diseases, including cardiac failure. So we should know that.
It will exacerbate conditions like ischemic heart failure, valvular heart disease. And then we'll go to icterus.
Okay.
Conditions like obstructive jaundice, it can be seen in infective endocarditis. And
jaundice is a feature of infective endocarditis. Obstructive jaundice is a different entity. Jaundice is seen in infective endocarditis.
And also in sinus bradycardia.
Sinus bradycardia can be produced by obstructive jaundice.
Then we'll go for clubbing.
Okay.
Clubbing will be seen in more congenital heart diseases like Eisenmenger syndrome.
Okay.
Then we'll go for lymphadenopathy. In lymphadenopathy, mostly seen in viral diseases.
Okay, they can have cardiac disease very well. Okay, so they all got some interconnections. Students should know all about this.
Then finally, bilateral pitting edema.
Okay.
That is mostly seen in congestive cardiac failure.
Okay, it's a feature of cardiac failure, especially congestive cardiac failure. Congestive cardiac failure means it is right ventricular failure, whereas cardiac failure, what we tell is that is left ventricular failure. Congestive cardiac failure means pedal edema, ascites, hepatosplenomegaly, all these things. Okay.
Now we'll move on to pulse, BP and JVP.
Okay.
So the pulse, why it is important, because in cardiac patients there can be tachycardia, rapid ready pulse. Then there are different types of pulses, like irregular pulses will be seen in atrial fibrillation.
Okay. So you have to see whether it is regular or irregular or irregularly irregular, high volume pulse, low volume pulse. All these things are important in cardiac examination. Okay.
And also wide pulse pressure can be seen in aortic regurgitation.
Aortic regurgitation is a classical condition, but physiological condition like pregnancy, anemia, thyrotoxicosis, beriberi, there also you can get all these things. Okay.
Okay. Now blood pressure, why it is important? Sometimes if there is a cardiac enlargement, that will be seen when the systolic BP is very high.
So either because of hypertension, cardiac enlargement can happen, or some conditions like aortic stenosis, the BP can be low, really low because of the aortic stenosis. So low BP or high BP, low BP is I already told that cardiac failure can produce low BP. Okay. So all these things are very important as a part of clinical examination and also as a part of cardiac examination.
Then we'll move on to JVP.
Okay.
JVP is basically the highest pressure in the oscillating column of blood, the highest point of pressure. That will indicate the right atrial pressure. So for JVP examination, first we have to incline the patient at a 45-degree angle, which has already been done.
In 45-degree angle.
And expose the patient, take consent.
Okay.
And then we have to use 2 scales.
Okay.
2 scales and a torchlight.
Okay.
So first we have to find the highest point of pulsation. Here in a mannequin we will not be able to find. Highest point of pulsation along the sternal angle.
Okay.
And usually JVP will have multiple pulsations, but carotid artery will have single pulsation.
And the carotid artery is not, we cannot obstruct that, but whereas JVP we can just obliterate, we can block it. Okay.
Yes. Then we use another scale and keep it perpendicularly.
It is not like that exactly. I'll tell you. You keep one scale like this, and another scale you lift it. You lift it. Okay. Now we count the centimeters.
And then we have to shine a torch.
You have to shine a torch to see the uppermost pulsation. So whatever you are getting, that should be added. Another 5 should be added. So you get a jugular venous pressure. Okay. So for an MBBS student, this is enough. How to calculate the JVP or jugular venous pressure is more important. But as a clinical practicing doctor, what is more important? What is the importance of elevated JVP?
Elevated JVP, certain conditions like fluid overload,
Okay.
right ventricular failure.
Okay, so classically what you learn is right ventricular pressure changes. It can be tricuspid regurgitation, tricuspid stenosis, aortic stenosis. So many conditions can produce right atrial pressure changes that will be reflected here. But in a normal clinical practice, if JVP is elevated, means it is volume overload. It can be cardiac failure induced volume overload or volume overload due to some other reason like cardiac liver failure, kidney failure, volume overload, fluid overload. All these things can be can produce a elevated JVP. So in simple words, if you are seeing a patient who is having elevated JVP, first thing should come to your mind is it's a volume overload condition. Then only all other problems come. Okay.
Okay. Now we'll move on to inspection. On inspection, we'll see if the trachea appears central or not.
Okay.
So here the trachea, if it's a normal patient, trachea appears central.
Okay. The importance of trachea and mediastinum is when the trachea or mediastinum is shifted to right side, the whole heart can also shift to that side. That is the importance of trachea in cardiac examination. Okay.
And if there's like a large pericardial effusion, then there will be a lower mediastinal shift.
Okay.
Next, we'll go to the apical impulse, which is the left lateralmost visible.
So, ideally, when you're looking at the precordium means a heart area, chest area coming in front of the heart. So that how to examine is this patient should be in straight on a straight bed, and you have to look like this. From there, you have to look like this.
That is what precordial bulge.
Okay, so you can see the precordial bulge. Either from the lower part of the patient, you look like tangential like this, or from that side, you look like this, so that you can see one side of the heart is bulged. Okay.
Then that is the apical impulse.
Okay.
And
so
then
apical impulse, where normally you localize?
Normally, it will be half centimeter medial to the mid-clavicular line on the left side, left fifth intercostal.
Okay. It's outermost and definitely cardiac impulse. Okay.
Yes, sir. Then we'll check for any other visible pulsations.
Okay, you have to look for a lot of other pulses. Apical impulse is already, you have told, parasternal pulsation can be there, second space pulsation can be, aortic space pulsation can be there, carotid area pulsation there.
Epigastric.
Whatever epigastric pulsation, whatever pulsation you are seeing, you have to document that because every pulsation will have some clinical importance. Okay.
Epigastric pulsation, that is in aneurysm.
Okay, aneurysm.
Then we'll see for any dilated veins or anything.
Okay. So dilated veins, especially when you are seeing a lot of dilated veins in the neck area, you have to suspect SVC obstruction. If you have seeing a lot of veins dilated on the abdomen, then IVC or chronic liver disease can happen. Okay. Chest veins normally we don't see, but a patient who is having SVC obstruction, neck veins, upper limb veins, chest veins, everything will be dilated. Okay.
Then we'll see if there are any scars seen.
Okay.
If there's a sternal scar, it's usually coronary artery bypass graft.
Okay.
And if it's a left scar, then it will be usually a valve
replacement. Okay.
Then we'll move on to palpation.
Okay.
Palpation, now we have to confirm all the findings from inspection.
Okay.
So we'll check if the trachea is central or not.
Okay.
Then we have to again confirm with the apical impulse.
Okay.
There's a three-way method.
Okay.
So first is you have to use your palmar surface.
Okay.
Then the ulnar border.
Okay.
And then you point with your finger.
Okay. So initially you just feel the pulsation like this with your whole palm. Okay. So you can get the pulsation. Then once you get the pulsation, you have to localize. That is very important. Okay.
Yes. Now after you localize, then you check which space it is. Usually left fifth intercostal space.
Okay.
Half centimeter.
Okay. When you are palpating, you should also tell what is the character of pulsation. So there are two important characters. One is normal pulsation, you already know. It's a gentle tap. Okay. But there are some conditions you get tapping. Okay. What is tapping apical impulse?
Tapping apical impulse will be seen in condition like mitral stenosis.
Okay. So tapping apical impulse, you can just simply tell that it's a palpable first start sound. Palpable first start sound is seen in mitral stenosis, whereas hyperdynamic apical impulse you get in a lot of conditions, including mitral regurgitation, aortic regurgitation, volume overload, thyrotoxicosis, beriberi, pregnancy. All these conditions you get hyperdynamic apical impulse. Okay.
Then there's
heaving apical impulse.
Heaving that is in pressure overload.
Okay.
Like in hypertension
and aortic stenosis. It taps your finger, your palpating finger, and it can lift your finger and it will be sustainable. Okay, that is hyperdynamic heaving apical impulse. So not hyperdynamic heaving apical impulse. Okay.
Then double apex.
Double apical impulse is classically seen in
hypertrophic
cardiomyopathy. Okay.
Also in aneurysms it can be seen. Then sometimes there will be a postural displacement also, like outwards and downwards. That usually, if it's it will be a left ventricular hypertrophy.
Okay, you can continue.
Then after that, we'll check for parasternal heave. Parasternal heave, you have to use the right ulnar border along the left sternal border. And also you can put a scale and then you can just see if it's moving.
You can just keep the scale on the precordium and see how it is moving. Normally in a normal person you never see this parasternal heave. But there are some conditions where there is a right ventricular hypertrophy, left atrial enlargement, all these things you can get parasternal heave. I am not telling what are the conditions, but you have to look for that.
Then you have to check for any visible, palpable murmurs and pulsations.
Murmurs are called as? Palpable murmurs are called as thrill.
Thrill.
Thrill is a palpable murmur. When you are getting a thrill in your hand, when you are palpating hand, if you are getting a scratch like thing, you have to tell there is a thrill there, that area. What is the importance of thrill?
Depending on which area, like if it's in the left or right intercostal space or left intercostal space, it can be like a pulmonary hypertension.
Whatever it is, any cardiac lesion can produce a murmur. But murmur can be due to a physiological condition or pathological condition or even due to a non-cardiac condition like anemia produces murmur. But if you are getting a thrill, that indicates definitive cardiac lesion under that area. Suppose if there is a thrill in the mitral area, in the systole, you have to confirm that there is mitral regurgitation. But other hand, if you are hearing a murmur, you are not getting thrill, it can even because of anemia or something else. So a thrill indicates definitive cardiac lesion.
Then after seeing all that, and even epigastric, it can sometimes be a right ventricular pathology. Now we'll move on to percussion. Percussion, now we have to percuss all the areas.
Clearly tell that in mannequin percussions are not possible, but for the for the clinic students' convenience we are doing it.
Now we'll percuss in each area. First the mitral area we'll percuss. The tricuspid area.
Tricuspid area is here. There is a tricuspid area. So mitral area, wherever you are getting the thrill or apical impulse, better to percuss there and see that is the mitral area. Wherever you are getting the apical impulse with your finger, that is a mitral area. Then tricuspid area.
Then right second and left second intercostal space. Right is aortic and left is pulmonary.
So these are the 4 areas you have to percuss, and one more area you have to percuss. Nowadays the importance of percussion is coming down because we have a lot of other investigation which can tell you the same diagnosis. One is if you are getting a apical impulse here. And if you can percuss from the in the axilla to this area, and if the percussion note is beyond this apical impulse, then you have to suspect a cardiac enlargement. Like that, parasternal area, normally parasternal area, the percussion ends with the sternum. There is a percussion dullness after the sternum, then you have to suspect something dilates that side also. But the importance of percussion nowadays is very, very minimal. And if you are getting a dullness in the second space, left, you have to suspect pulmonary hypertension. So these are the minimal things you have to tell about percussion.
And right, usually we go downwards till we get the liver dullness.
So you have to check the right also, and you have to tell that normally an MBBS student should tell that cardiac border corresponds to
the sternal
border.
So after this cardiac border will correspond to the sternal border, and from the apex of the axilla, as you said, sir, to the apex of the heart.
And so there also you have to tell my percussion note corresponds to the apex.
Next we move on to auscultation. Now auscultation, the same areas that we percussed, we have to auscultate. And then
so you have to auscultate with the diaphragm.
Auscultate with the diaphragm.
Not well.
This part. So then first we auscultate with the mitral area.
So wherever you are getting the apical impulse, there is a mitral area, there is a first area you are going to auscultate. What are the findings you are going to get in a normal person?
Normal person, the mitral and tricuspid area will be seeing the S1, hearing S1 and S2.
Normally, you are hearing, actually, you are going to concentrate only S1.
Okay.
S1 is produced in mitral area and tricuspid area.
And S2 will be in pulmonary and
aortic. But as MBBS students, we all write S1, S2 heard in mitral area. It is normal. Okay. So how do you know that it is S1?
S1 usually, how do we know whether
how do you know that you are getting left dub?
Yes.
But
yes.
which one is left, which one is dub? How do you count?
Oh.
So for that you have to take the timing of the carotid. So you palpate the carotid and hear the sound, and if you concentrate, you can know that first third sound always correspond to your carotid impulse, not the JVP, carotid impulse. So whenever you are getting a pulse, you are getting the first third sound. That is a first third sound. Other one is second third sound.
Okay.
So first third sound, second third sound. Okay. If I ask you some questions like which are the conditions first third sound will be muffled?
Yes, sir. If it's like a soft
Muffled,
S1,
soft.
then it can be seen in mitral regurgitation.
So mitral regurgitation is the classical condition which produces soft S1 for an MBBS student. Which heart disease can produce a loud S1?
Loud S1, mitral stenosis.
Mitral stenosis. So these are the two conditions you should know. No need to learn a lot of things. Mitral regurgitation produces a soft S1 in the mitral area, and mitral stenosis produces a loud S1 in the mitral area. Same like if you oscillate in the tricuspid area. If S1 is soft, then it is tricuspid regurgitation. Yes. S1 is loud, then it is tricuspid stenosis.
So we'll auscultate in the tricuspid area.
Okay.
Now in the mitral, as you said, S1 is the one which we have to focus on.
Okay. You have to focus only S1 in mitral and tricuspid area.
And there can also be murmurs like pansystolic, mid-diastolic murmurs.
Okay. So if you don't take that stethoscope, it will rub on the mic. Okay. So what happens is you have to see whether any added sounds are there. Okay. So you are told something about murmurs. Okay, there are systolic murmurs and diastolic murmurs in the mitral area and tricuspid area. So again, I am asking this question: how do you know that it's a systolic murmur? How do you know that it's a diastolic murmur? Again, time with your carotid.
Okay.
First third sound, second third sound. Whatever comes in between first third sound and second third sound, it is a systolic murmur. Whatever comes before that, it's a diastolic murmur.
Okay.
For that, to learn that skill, you need to oscillate a lot of patients and you need to time with the carotid. Okay. So whatever it is, suppose you have a patient who is having a murmur in between first third sound and second third sound. This is called a systolic murmur. Okay. So again, in systolic murmur, you have various systolic murmur. You have pan-systolic murmur, and you have a short systolic murmur and long systolic murmur. Okay, a systolic murmur simply indicates for an MBBS student a regurgitation lesion in that area. Yes. It can be due to hemic murmurs like anemia, thyrotoxicosis, beriberi, all these conditions you can get murmurs, but a cardiac lesion which produces systolic murmur is mitral regurgitation. So what will be the mitral regurgitation events? You can get soft S1
and
you get a pan-systolic murmur. Whereas mitral stenosis?
Mitral stenosis, mid-diastolic.
So you have first third sound loud and
loud S1.
Mid-diastolic murmur. And sometimes if you are very skillful, you can auscultate about opening snap, all these things. Okay. So first third sound is called, loud first third sound is a closing snap. It's a closing sound. Okay. Tight valve closes with a sound, tight valve opens with a sound. That closing sound is first loud S1. Then there is a mid-diastolic murmur. Then there is an opening snap. Okay. So all these things you have to explain in detail. Okay. Whereas in tricuspid regurgitation, same events.
Yes.
Okay. Tricuspid stenosis or regurgitation can be there. Okay. But normally for an MBBS student, you get tricuspid regurgitation than stenosis.
Okay.
Because mitral regurgitation, aortic regurgitation, all these conditions ultimately lead to dilatation of right ventricle, and tricuspid regurgitation is a classical condition. Okay. Okay.
Now the pulmonary and the aortic areas.
Okay. So one more question can be asked. Yes. How do you differentiate between a right side, that is left-sided murmur, that is a left ventricular murmur, and right-sided murmur?
So that we can do dynamic auscultation.
Okay, so you tell one of the dynamic auscultation.
When you inspire, then all the right-sided sounds will augment.
Okay, so this is called as Carvalho sign, D Carvalho sign. When you take a deep inspiration, all the sounds produced from the right side will be augmented. When you take an expiration, all the sounds produced from the left side will be augmented. Okay, so that has to be documented. You have to write. There is a like soft S1 here. There is a pan-systolic murmur which increases or decreases with the deep inspiration. So that will tell you that whether it is a left-sided murmur or right-sided murmur. Okay, next one.
Then we move on to the left and right second intercostal space, which is corresponding to the pulmonary and aortic area.
Okay.
Now, first of all, S2 is divided into two. That is A2 and
so
P2.
Even S1 is divided into two, but we are not, as an MBBS student, we don't tell it is M1 or T1. Okay, we just tell S1. But whereas S2 is divided into P2 and A2 and P2. Okay.
That is pulmonary and aortic.
Okay.
Now, sir, loud A2 and loud P2 also.
Okay, you have to concentrate very few things as an MBBS student.
Yes.
Which condition produces loud P2?
Loud P2, pulmonary hypertension.
Pulmonary hypertension. Which condition produces loud A2?
Systemic hypertension.
So these are the two things an MBBS student should know. Pulmonary hypertension produces loud P2. Loud A2 is produced by systemic hypertension. Now tell me one condition which produces soft A2, reduced A2.
Aortic stenosis.
Aortic stenosis. Aortic stenosis is the one condition which don't allow the heart aortic valve to close. It slowly closes. So aortic stenosis produces soft A2, whereas pulmonary stenosis produces soft A2. This one. Okay. So
and if there is a cardiac lesion also, then the interval between A2 and P2 might increase.
Okay, so that also there are few conditions like suppose you have a systemic hypertension, A2 P2. You know that A2 P2 is in a concentric lesion like systemic hypertension or some other thing. A2 can be slightly prolonged. Okay, so like that, if you can concentrate and auscultate, you can get to A2 P2 prolongation. Fixed A2 P2. So there are so many things, but since we are telling basic examination, that all will not come. Okay. So that is auscultation.
Then two more areas.
You have to tell the murmurs there.
Murmurs in the
aortic area and pulmonary area. If there is an ejection systolic murmur in the aortic area, what are the differential diagnoses?
Ejection.
There are a lot of mistakes you can produce. Is mitral area you are told about pan-systolic murmur. Some students say that there is a pan-systolic murmur in the aortic area. Systolic murmurs in the aortic area, pulmonary area are ejection systolic murmur. They are not pan-systolic murmur. So A2, S1 is there, then there is an ejection systolic murmur, then there is A2. Okay. So what are the conditions which produce an ejection systolic murmur in the aortic area?
Aortic regurgitation.
Ejection systolic murmur. Aortic regurgitation can produce an ejection systolic murmur, but that is a hemic murmur. Ejection systolic murmur, the classical condition is aortic stenosis.
Okay.
Aortic stenosis produces soft A2, ejection systolic murmur, but in that condition, what will happen to the pulse? Aortic stenosis produces very low pulse. Low pulse. Okay. What will happen to the systolic BP?
That will also
very
decrease.
Low. Decrease, or it is called as systolic decapitation. Whereas a condition that is called as aortic sclerosis. Most of the elderly people after 50 years will have this murmur, aortic sclerosis murmur. That also produces an ejection systolic murmur. Okay. So the differences are, in aortic sclerosis there is no soft A2, there is no thrill. Okay, and pulse will be normal volume. BP will be normal or slightly higher. Okay, so these are the two important conditions you should know as an MBBS student. And again, lot of other conditions like anemia, thyrotoxicosis, beriberi, all produces hemic murmur, and hypertrophic cardiomyopathy also can produce this murmur. And you are told about aortic regurgitation can produce ejection systolic murmur. So because of aortic regurgitation, lot of volume will come back to the left ventricle. That is ejected out. Okay, during that period you get a hemic murmur. This is called as hemic murmur. More flow occurs through the valve. So a murmur is produced because either through a normal valve with an abnormal flow, or an abnormal valve with a normal flow. Okay. So in aortic regurgitation, you are getting an ejection systolic murmur is not because of the abnormality in that valve in that phase. Okay. lot of blood has come back to the aortic area, that is ejected out. Okay. Now tell about regurgitation murmur in the aortic area. Aortic regurgitation.
Aortic regurgitation, sir. The murmurs in the aortic regurgitation.
Aortic regurgitation, what type of murmur you get?
I don't
It's an early diastolic murmur.
Early diastolic.
Early diastolic murmur means aortic, left ventricle pumps out blood. Okay. And since the valve is not getting closed, it come back to the left ventricle. So aortic regurgitation produces a early diastolic murmur. But what you should understand is, for an MBBS student, it is very difficult to identify early diastolic murmur. For that, you have to correlate. You have to see that whether the patient is having cardiac failure features. What will happen to the pulse? There will be high volume pulse, BP. There will be wide pulse pressure, increased pulse pressure, and you get a water hammer pulse. Then you are not, ideally you don't get anything in the aortic area. You get in the neo-aortic area, sub-aortic area. You make the patient to sit and lean forward and auscultate. You can get a early diastolic murmur in the aortic area. But most of the time you have to correlate. You have to see what is a pulse, you have to see what is a BP, and you have to see cardiac failure features are there. Then you get early diastolic murmur. You may or may not get. Okay. So that will be aortic regurgitation. Then pulmonary area.
Pulmonary area, the different murmurs, sir.
What are the murmurs you get?
In pulmonary area,
You get an ejection systolic murmur, you get an regurgitation. Same. Aortic stenosis produces an ejection systolic murmur. Pulmonary stenosis also can produce an ejection systolic. So almost it will be similar. Only thing, you have to ask the patient to take a deep inspiration and expiration, and where it increases, that is that side. Okay. For every murmur, you need to describe the murmur in a different way. Okay. For a mitral stenosis murmur, it will be a pansystolic murmur. It increases with inspiration. You can auscultate better on the left lateral position with your diaphragm. Whereas mitral stenosis, you auscultate better with your bell. Okay. Like that, other murmur also, you have to write in detail about the type of murmur. Okay. So that is cardiac examination. If you want
new areas are also there.
Neo-aortic area.
Neo-aortic area below the pulmonary area, left third or fourth intercostal space. As you said, sir, when the patient leans forward, aortic regurgitation can be there.
So there are
the carotid.
Carotid area you have to auscultate.
Conduction murmurs and bruit.
You should auscultate. Okay. So this completes the cardiac examination, but that doesn't mean that you have examined the patient fully. Okay. Other system like abdomen, what will you see?
Abdomen, sir, if the JVP...
Once the JVP is elevated, normally you can see only JVP. Suppose you suspect a patient with cardiac failure, but you are not seeing JVP elevation because you might have given Lasix.
Okay, how do you know?
You just press the left side of the abdomen, press on the liver area. You can see the jugular veins will be persistently elevated. Normally, if you press on any patient, it will be elevated and it comes down. But if in a cardiac failure patient, if you press it for some time, remaining there. Okay, so you can know that this is called as hepatojugular reflex. Okay, then right ventricular failure or congestive heart failure, you can get hepatomegaly, splenomegaly, pedal edema. Okay, conditions like infective endocarditis, you can get retinal changes, jaundice, you can get finger changes, so many things. So many changes can be there. And some heart disease, you can get stroke like atrial fibrillation. You can get stroke or other area infarcts can be there. Okay. So ideally, once you finish heart examination, you have to examine the patient as a whole and find out anything related to your heart disease is there or not. Okay. And once you complete your examination finding, you have to write all the findings. You have to write all the findings. Like for example, I'll tell you. An elderly individual is coming. He's having, you are seeing mitral regurgitation here. He had a chest pain in the past 10 days. Okay. Now, what is your assumption? What is your diagnosis? This is mitral regurgitation. Mild, moderate, severe, you have to tell according to your clinical finding. And what is the reason for that?
First of all, you have to diagnose with loud S1.
Okay. So you are diagnosing mitral regurgitation. Age is very important factor here. He had a chest pain in the past. So chest pain was there. Age is elderly individual. Now mitral regurgitation, he never had mitral regurgitation in the past. So this mitral regurgitation
can be due to the
valve pathology because of papillary muscle dysfunction
in the older
secondary, not in the older period, secondary to the myocardial infarction.
Okay.
So like that, you have to correlate with the associated illness. Like somebody, and young lady is coming, she had migrating polyarthritis in the past. Now she is having very tight valve. You have loud S1. You are getting a what is
mid
it? Not mid diastolic murmur. Then you have to suspect mitral stenosis secondary to
any autoimmune condition,
rheumatic
like
fever. Rheumatic fever. It is not autoimmune. It's a post-infective condition. Rheumatic fever induced mitral stenosis.
Okay.
So you have to always see the age of the patient, comorbidities, and you have to correlate and write your diagnosis. Then only you get a complete diagnosis. And after that, once you make a diagnosis, what is the next step?
Next, you have to go for the investigation.
Basic investigation. You have to take an ECG. You have to take a echo. You have to take an X-ray. And you suppose the patient is having fever, infective endocarditis, features. Count should be done. Blood culture should be done. Then treatment.
Treatment based on if it's an infective cause, then we treat the infection.
Okay. So if you are treating an infective endocarditis, you have to treat infective endocarditis. If it is a regurgitation lesion, you will have to valve replacement is required. If it is stenotic lesion, you can dilate the valve. Okay. If it is a pericardial effusion, you have to tap the pericardial.
Take out the fluid.
Okay. Like that, you have to write the treatment aspect of that disease, not in detail, but you have to give the basic details of the treatment. That also should be done. Okay. And prognosis also should be, you should be able to explain the prognosis of the patient also.
Okay.
Okay. That is also important. Okay.
Okay.
Okay. Thank you.
Thank you.